estimated it takes about 10 years from the time you get a polyp to develop cancer. Clear that we all need to do colon cancer screening. I hope to take you through a journey where you can understand what colon cancer is. Welcome to my podcast. My name is Dr. Edna Kamau. I'm a consultant gastroenterologist and physician based in Nairobi. I'm basically the doctor who takes care of your gut health and liver diseases. This month, I'm going to discuss a very timely topic. March is a colon cancer awareness month, and hence we're going to be discussing colon cancer in Kenya. So I'm sure you're all aware of colon cancer has become very popular. In the recent past, we've had quite a number of prominent people succumb to colon cancer, and hence the importance of this topic. I hope to take you through a journey where you can understand what colon cancer is, how it presents, the risk factors, how we make a diagnosis, how we treat colon cancer, and more importantly, how we prevent colon cancer through screening approaches. So what is colon cancer? Colon cancer is cancer of the large intestines, or the colon, and the rectum. The two are separated because the treatment approaches are different. A cancer basically refers to an overgrowth of normal tissues that can spread. So when a disease can spread, that's when we refer to it as cancer. If it is localized and cannot spread, it is referred to as a benign tumor. So colon cancer happens to be very, very common in Africa and in Kenya in particular. It's actually the 5th most common cancer in the country, following breast cancer, prostate cancer, esophageal cancer. Of note, however, it's that there's an increasing incidence of colon cancer in the country. And more importantly, the incidence happens to be increasing amongst the younger people. So it's no longer a cancer of the older people. And this is true across different populations. In particular, in Africa, we find a number of patients who present with colon cancer are below the age of 50. And importantly, they present when they're late, when very little can be done. In developed countries, like for instance in the US, because of a lot of screening programs, the incidence of colon cancer has reduced in the elderly people, but they have found increasing cases of colon cancer in younger people. And I'll come back to what we postulate as possible etiologies. So colon cancer, we mostly refer to colon cancer when you're referring to adenocarcinoma. There are other different kinds of cancers that can be present in the colon. We have what we call lymphomas. We have neuroendocrine tumors. We can have gastrointestinal stromal tumors. But 95% of colon cancers are in a group that we are referred to as adenocarcinoma. And this is important because these are tumors that in 95% of cases arise from a polyp. A polyp is a small swelling that develops on the lining of the intestine that takes time to grow over time. It's estimated it takes about 10 years from the time you get a polyp to develop a cancer. And that gives you a lot of time to be able to prevent and have early management, and hence the importance of colon cancer screening as a way of prevention of the disease. In cases where you have colon polyps, it's only about 5% of the polyps that progress to colon cancer. But as I said, it's a long period of time, 10 years, hence the importance of evaluation and screening guidelines. So how does colon cancer present? Most patients with colon cancer are usually asymptomatic, can present in an asymptomatic way. They might not have any symptoms, and you can diagnose it during screening. For instance, if you do a colon cancer screening strategies, a patient comes for colonoscopy, or you do a stool test, you can identify colon cancer. And the good thing about that is that you're going to identify it when it is in an early stage. Some patients, however, are picked incidentally also. For instance, you do your routine medical checkup, and then you're found to have low iron levels. And in the evaluation of the causes for the low iron levels, especially in elderly patients, in male patients, in postmenopausal women, then one of the approaches that we check when you have low iron levels is to look at the colon. And in that case, colon cancer can be a presentation. You can also have diagnosis made without symptoms. For instance, when you're doing your routine tests and you have a scan done and you find the disease that has gone to other places, for instance, the liver, which is a common site of spread of the disease. For patients who present with symptoms, they can either present as an emergency, and this accounts for about 30% of people will present as an emergency to the hospital with obstruction of the intestines, where they'll be vomiting, they'll be not passing stool, they'll have abdominal distension. They can also present with bleeding, which can be in the lower intestine, so they present with blood in the stool. Or they can present with a perforation where they come to the hospital as an emergency because the intestines have perforated. There are people then who present with other cold symptoms, and these are mostly altered bowel habits. So as you grow, most of the times you'll have a routine bowel pattern. You might know maybe you go one every day or every other day. A shift from that pattern should trigger an evaluation, because if a tumor is developing in the colon, what happens is that the caliber of the intestine changes, and so you begin to have a change in the way you go to the toilet. The second presentation can be changing the caliber of the stools, where they become thinner. If the tumor happens to be on the lower areas of the colon, we call that the left side of the colon, a presentation could be presence of blood in the stool or mucus in the stool, or a feeling of incomplete emptying. So some patients find that when they go to the toilet, they don't feel like they're finishing to go to the toilet. They want to keep going back and back. We call that tenesmus, and they have an urgency to always go back to the toilet. Again, that could be a presentation of colon cancer. Other presentations are abdominal pain. However, this is not a very early presentation, and the abdominal pain usually is crampy pain, usually associated with going to the toilet and eating. You could have an increase of your bowel movement, so you start feeling a lot of noises in the abdomen, and also weight loss and non-weight loss. Those are the classical presentations. The classical presentations account for about 60% of the symptoms when patients present, with 30% of patients having emergency presentation and the diagnosis being made as an emergency. So once a patient has symptoms suggestive of colon cancer, how do we investigate these patients? If you have symptoms, we have to do tests that allow us to look into the colon. So the first thing is that we have to have an index of suspicion. As a patient, you must think, could it be possible that I have colon cancer? The clinician seeing you should also have a high index of suspicion. And of note is that this disease, as I say, does not only affect older people, so even young people presenting with these symptoms should be evaluated. One of the misrepresentation is actually rectal bleeding. So many times patients will go to the hospitals and will be told they have hemorrhoids, and they'll attribute their rectal bleeding to hemorrhoids or piles, yet there could be an underlying problem. So I always say, if you have rectal bleeding, we have to evaluate you for colon cancer if you fit the profile before we can blame the hemorrhoids for the rectal bleeding. So once we make we suspect you have colon cancer, the first test that should be done is a colonoscopy. A colonoscopy is a test that involves putting a tube into a clean colon that has a camera, that the tube has a camera that allows us to visualize what is going on inside the colon. Once you put the colonoscopy in, which is a camera, you're able to identify the tumor, and you can be able to collect samples that are taken to the lab for pathological analysis, to confirm whether you have a cancer. And the way that the tumor presents inside the colon can be either there's a swelling inside the colon, so that means that when the doctor who's doing the procedure goes in, they'll see a big swelling, or it can be a flat finding, so it can be a very obscure, very minimal finding in the colon, and hence the importance of making sure that you have a good quality colonoscopy as the test is being diagnosed. Once the samples are taken to the lab, the pathologist then confirms the diagnosis when they find malignant tissues on the samples submitted. In some circumstances, you might not be able to do a colonoscopy because the patient presents as an emergency, and in that case, if the patient goes to theater, what is presented is a surgical sample that is then analyzed. In some cases, the patient is obstructed. You might have to do CT scan imagings to be able to show you that there's a tumor, and the patient goes for surgery. surgery. But the diagnosis of colon cancer is hinged on a pathological sample. The other tests that are done that suggest colon cancer would be your blood levels could be low because you could slowly be losing blood. So you find that you have iron deficiency, anemia, or low blood levels suggestive of loss of iron. So patients who have persistently low iron levels, you have to make sure that the colon cancer is excluded. You should not be started on iron supplementation without excluding colon cancer, more so in patients who are more than 45 years old. Postmenopausal patients, male patients should not have iron supplementation without exclusion of an underlying GI pathology, gastrointestinal disease as a cause of their low iron levels. The other tests that are done after the diagnosis is made, then the doctor has to decide how do we treat this disease, and so we go on to do what we call the staging tests. And one of the tests that's very important are CT scans, and we do CT scans of the abdomen, of the pelvis, and of the chest. These are important to tell us, is a disease that we have found localized or has it spread? Because this determines the treatment. For patients who have localized disease, then surgery is usually what is important. But if the patient has extensive disease, then other modalities become important. And so again, a good quality CT scan is then important to make the diagnosis. So once the diagnosis is made, the staging of the disease is then done, and by this time we'll have brought in another specialist, and these specialists are called oncologists, and they guide us treatment. The treatment of colon cancer is hinged on three things. The first thing is the location of the disease. The second thing is the stage of the disease. And then finally, the overall state of the patient. So based on the stage of the disease, they can have the disease either within the colon itself, where it has not extended beyond the walls of the intestines. In the early cases of the disease, you might have disease even on the intestinal wall. And in some cases, we're actually able to do complete endoscopic treatment in very early disease. If, for instance, you're doing a colonoscopy and you find a very small swelling that is very limited, it can be removed completely endoscopically. However, this is very unlikely. Majority of the patients will have the disease extending to the intestinal wall, in which case you have to remove that section of the colon in what we call in medical terms hemicolectomy. You remove a section of that colon so that the disease doesn't spread. As the surgery is being done, the surgeon also analyzes a bit more on the extent of the disease. So lymph nodes are removed that are taken to the lab, that are checked to see whether there is any disease, because that determines whether the surgery that has been done is curative or the patient will require more additive treatment in forms of chemotherapy or radiotherapy to prevent recurrence. In patients who have, and that is majority of the patients will benefit from surgery. The key treatment approach for actually colon cancer is surgery. And this applies for patients who have disease that is limited to the colon or has just slightly spread into the surrounding tissues. There's a group of patients who present very late. We call them stage 4. And these are patients who have diseases in distant organs. The way the colon cancer spreads, it spreads by direct extension, but also through what we call the lymph nodes and the blood. Because the intestines are very intertwined with the liver, the first spreads that the colon cancer spreads to is actually to the liver. So you get liver disease, liver metastases, and also to the lung, especially for for cancers of the rectum or the lower part of the intestines. So if a disease has spread that far, then the first approach is usually medical treatment with chemotherapy or radiotherapy, after which the disease can be reduced in size. And in some cases, if the patient has obstructive symptoms, there's a role for surgery, post-chemotherapy, or to ensure that the patient gets comfortable. In some cases, the patients who have lower tumors in the rectum may require that they get a bag fixed on their wall so that they can be able to pass stool, because they will not be able to have their normal mechanisms to go to the toilet. But in a nutshell, the key of treatment is surgery, and that applies to majority of the patients who are diagnosed early, which is where we hope most of us, if we make the diagnosis, will find our patients before it has spread, because It's a very good, has good outcomes when it is diagnosed early. We've had a lot of advancements in treatment, and I'm finding a lot of patients we treat, we follow them up for years. Many patients we are following up over years who have had surgery, good surgical outcomes, chemotherapy, and are doing well, and you wouldn't even tell they had colon cancer at all. Even in patients who have late disease, there's been a lot of advancements in chemotherapy, the new therapies that are coming up that are actually able to help with the treatment. And even the life expectancy for patients who have advanced disease has over the years improved. So what are the risk factors for colon cancer? As with all cancers, colon cancer increases with age, so we find more older people presenting with the disease. But as alluded to earlier, we're finding the disease also in younger patients. We have a higher increase of the disease in the younger population. The second risk factor is a family history, and this is key. If your relative has had colon cancer, it puts you at a higher risk of colon cancer. When is that risk most important? It's most important if the person who had colon cancer had it before the age of 60, or if you have several of your family members who have had also colon cancer, but also in patients who have had a family history of what we call an advanced polyp, a large polyp in the intestines. These are the growths that precede the development of colon cancer. So if your relative had a large polyp or had colon cancer, especially before the age of 60, or multiple family members who have had colon cancer, and I'm referring to first degree relatives, that is your brothers, your sisters, your parents, or if you've had your second degree relatives, irrespective of whatever age, more than 60 years old, if you're several, more than 2 who have had colon cancer, that puts you at a higher risk. And in fact, it puts you at twice the risk of colon cancer to general population. Then we have genetic predispositions. About 10% of colon cancer appears within genetically predisposed people. Some of the risks include cancers that are linked to the digestive system. We have syndromes we call the Lynch syndrome, and you'll find these are tumors that aggregate around the ovaries, the endometrium, breast cancer, pancreatic cancers. So those kind of cancers can have a genetic predisposition. So if you have a strong family history of that, it's important that you're screened for colon cancer. You can also have other genetic predispositions that predispose you to getting very small polyps in your colon when you're very young, and this puts you at an extremely high risk of colon cancer by the age of 40 years old. Then we have environmental factors. The environmental factors that are important, one, are the change of diet. There are multiple studies that have linked colon cancer to diets that are low in fiber, low in fruits, high in processed foods, and high sugars. And that is why colon cancer for a long time was thought to be a disease of the West. As you very well know now, we have a shift in our dietary habits, and a lot of Kenyans are now eating a lot of processed food because they're cheaper, they're more available, and we might be thinking these are some of the reasons why colon cancer is rising. And we expect that these figures will keep rising in the near future given the dietary changes. Other risk factors include obesity. There's a direct correlation between obesity and cancers, and in particular colon cancer. Sedentary lifestyle, so you're jogging every day, your 30 minutes of exercise comes a long way in preventing colon cancer. Obesity has been linked, and as I said, obesity increases your risk, but once you lose weight, the risk also has been found to decrease, and we encourage patients to take up healthy lifestyles to reduce the risk of colon cancer. Again, smoking has been attributed, and as well as alcohol intake. Those are the key risk factors. Some of them are modifiable. We have a few non-modifiable risk factors for patients who have inflammatory bowel disease. These are diseases of the intestines that cause inflammation, and that continuous inflammatory process or disease or in the intestine predisposes them to colon cancer. Now, how do we screen for colon cancer? Screening of colon cancer, it depends on what your underlying risk. Are you a high-risk patient or are you an average-risk patient? So average-risk patients refer to patients who do not have any family history of colon cancer and have no underlying colon diseases. So they do not have inflammatory bowel disease, they have no family history of colon cancer, and they do not have a family history of advanced polyps. And the guidelines that are developed are separated into those two categories: average risk patients and patients who are high risk. Let me begin by discussing average risk patients. Average risk patients, the cancer screening guidelines in Kenya were developed in 2018 and rolled out in 2019. And they recommend that any patient over the age of 50 years old should do colon cancer screening. In patients who have a family history of colon cancer, we begin colon cancer screening much earlier, and this is determined, or these are the high-risk patients. We begin colon cancer screening based on the age of the family of the relative who had colon cancer. We start 10 years earlier than when the relative had it. For instance, your brother has it at 50 years old, you start at 40. Your brother has it at 45, you start at 35. So 10 years earlier. And this is based on the fact that we know colon cancer follows a cascade in development that takes about 10 years. So you want to be able to identify colon cancer way before the polyp, if there's a polyp, before it develops. For patients who are average risk, you begin at, as I said, 50 years old, and the ones who are high risk, depending on the age of the relative. Again, if you've had how many relatives, if your relative had less than 60 years old, you begin colon cancer screening at 40 years old. If you have more than 2 relatives, even if they're more than 60 years old, you want to screen at the age of 40. So 40 years if you have 1 relative less than 60 years, more than 40 years even if you have 2 relatives, even if they are more than 60 years of age. And again, if you have earlier cancers, the age also drops depending on the age of the relative. So how do we screen for colon cancer? The screening again depends. If you're high risk, that means you have a relative, you have an underlying disease, your only option of screening is colonoscopy. And depending on what is found on the index colonoscopy, it determines your subsequent colonoscopies. But your colonoscopy subsequently will have to be 5 years. This is different from patients who have average risk, patients who don't have a risk don't have a family risk and do not have underlying diseases, where we begin screening 50 years old. Notice that in America, in the US, there's been a shift to 45 years age as a starting age. And this has been particularly so for the Black Africans. And this has been hinged on the fact that most of the diseases are found earlier, they have a later presentation. And for my patient, I actually prefer to start at 45 years old if I can. I believe our colon cancer follows the Black African type, and so 45 years is an appropriate age to start. So at 45 years, if you're an average risk person, the way you should screen for colon cancer, there are different approaches. You can have what we call stool tests. And the stool test, there are 2 kinds of stool tests you can do locally. We have the fecal occult blood. That is where you look for blood that is digested in the stool. This test requires, ideally, you should have 3 samples. You should be off meat for 3 days. You should not be on any medicines that can cause ulceration for about a week. The accuracy of this test is not as good because it can also can detect problems in the upper GI, like if you have small ulcers. So that is not our preferred approach. Our current preferred approach is something we call a fecal immunochemical test. And this is a test that is very widely available. And the test, what it does, it looks at the antibodies, which are small molecules that are produced by blood. If they are detected in the stool, all right, it indicates that you're bleeding. All right, so that test is much more specific than doing what we call an occult blood. An occult blood is less specific because it looks at something we call the heme. So if you eat meat, it will be present. But this one looks at only the presence of human hemoglobin in the stool, and it's very sensitive. So once you do the stool test and the stool test comes out positive, then you have to progress and do a colonoscopy. So it's a it's a 2-staged approach. First stage, you start with a stool, which is effective because it's inexpensive, it's widely available, and when it is positive, you do a colonoscopy to confirm the findings. And based on what you find on the colonoscopy, you can either find a polyp or you can find a tumor, in which case then the treatment begins from that. In case it is negative, if you do a fecal immunochemical test, it is done every year. So you keep repeating it every year. So as you do your annual medical checkup, you should ask your doctor to include a stool fecal immunochemical test as part of the routine test for colon cancer screening if you're over the age of 45 years old. However, as I said, these do not apply for high-risk populations. This is for average risk population. Then there's the structural approaches for screening, or the one stage, the structural approaches. And the first one that is available and what is recommended is a colonoscopy. So a colonoscopy is a tube, as I alluded to, that is put inside the colon. In a clean colon, you're able to see even the flattest of lesions, which are small like protrusions. I look at them like pimples, small swellings in the colon, that some of them can be precancerous. You remove them, and that reduces your risk of colon cancer to 0. When we do our colonoscopies, what we find is what determines the subsequent evaluation. So depending on the number, if you have few number of polyps, depending on the type of polyps, there are different kinds of polyps. There are polyps that have precancerous risk, we call them adenoma, and these are the ones that over 10 years can grow into become colon cancer. Or if you have what you call hyperplastic, they do not have a risk. Finally, it depends on you can also have a phenotype that is very flat. We call that the serrated or the sessile types. So if your index colonoscopy is done and you don't have any polyps, you repeat after 10 years. If you have a polyp, depending now on the number, if you have more than 5 polyps, if you have a polyp that is more than 1 centimeter, if you have a polyp that has what we call high-grade dysplasia or precancerous cells, or you have a polyp that has something we call villus polyp, in that case, you're at higher risk and you're going to repeat your colonoscopy after 3 years. Otherwise, you repeat your colonoscopy if you have other smaller polyps, if they're low grade, after 5 years. So it's really a very cost-effective approach because you don't keep repeating. There are some circumstances we repeat after a shorter time, like a year, if the polyp was very big and we removed it in small pieces. In that case, we go back after a year. A good quality colonoscopy done, and a good quality refers to a colonoscopy done by experienced person. The colon is very clean, and the person goes to the end, and there's photo documentation of all the parts of the colon and the lesion that was found, then your chances of getting colon cancer are markedly reduced. Another approach is the use of a CT scan colonography. So the usual CT scans that are done, there are specific protocols that can be adhered to that can give 3D dimensions of the colon. You get a preparation similar to a colonoscopy. You get a CT scan done with infusion of contrast into the colon, and then you have a representation of the colon. That's called a CT colonography. It's a recommended approach. It has a good sensitivity. However, it has the downside that you cannot remove what you see. So you still have to go ahead and you can do a colonoscopy. Finally, it can also have the risk of missing lesions or polyps, which are very small. So in ideal situation, we'd like a colonoscopy. But in some situation, if a patient is obstructed, in that case, you might have no option but to do a CT colonography. Other approaches that are not recommended, the use of a colon capsule is not approved for colon cancer screening, so it is not recommended. Flexible sigmoidoscopy, where you just look at a part of the small intestine, is not again recommended. It's not a good recommendation, especially because you might miss the right side of the colon. It's ideal only in cases where you're limited in resources, in which case you can prefer, okay, let me start with a flexible sigmoidoscopy. But in ideal situations, you want to have a colonoscopy done instead. So once you have done your colonoscopy, then you go into what we call, you've had your colonoscopy or you had your screening. It's very important. Then there's a strategy on how you're going to follow up. And then we go into the polyp surveillance. And as I alluded to, the polyp surveillance is based on the size of the polyp, the number of the polyps, and the type of the polyps that you have. And that is important that you get in touch with your gastroenterologist, even if your colonoscopy was done in an outpatient setup, so that follow-up criteria is very well defined and is very clear. So I think I've alluded to the prevention, and it's clear that we all need to do colon cancer screening. Let me reiterate again: you start colon cancer screening ideally at the age of 45 in Kenya. If it's not possible, 50 is still good enough. You can either choose a stool test. If it's positive, you do a colonoscopy, or you can go straight and do a colonoscopy. And based on the findings, then you're able to progress and do the surveillance after that. What are the outcomes of colon cancer? Early detected colon cancer has good outcomes. Stage 1, stage 2. These are patients who have colon cancer limited to the colon. The outcomes are good. In fact, most of these patients are on follow-up programs. We have those patients coming for annual colonoscopy and they have good quality of life. Late presentation has a much more reduced quality of life and outcomes, but again, it still performs much better than most other GI malignancies. Thank you very much and looking forward to seeing you during my next podcast.